Okay, so thank you for showing us the poll results. I just asked a preliminary question about how your experience has been and with SBRT, and I'm just happy to see that the it looks like the majority of people are either very happy with SBRT or have not much experience with patients having received SBRT. So that's 50-50 for me. It's so I'll just take you through a. Sorry, can I show my screen, please? Sorry, so just a second. Yeah, so I'll just take you in 15 minutes, short a whirlwind tour, if you must, through the concept of SBRT in hepatocellular carcinoma. So the rationale for SBRT in hepatocellular carcinoma began around the 1990s to the 2000s, because prior to this, not much was known about liver tolerance. And because of the technical limitations of the machines available at that point of time, it was technically not possible to deliver conformal radiation. From the 1990s to the 2005s, there were, because of the technological advancements, people were able to actually administer partial liver irradiation. And several institutes from around the world contributed to the fundamental work which went into the development of this field. And it's really after the 2005s that this field really sort of took off. So the rationale, initially, the problem with delivering radiation to the liver was that we were thinking on the scale of whole liver radiation, and it was quickly realized that more than 30 gray was very hepatotoxic, and patients would land up with radiation-induced liver disease, which came to be a very feared complication of external beam radiation. So the tolerance for the whole liver was accepted as approximately 30 gray, and this was nowhere near the doses that we need to control hepatocellular cancers. And so radiation sort of fell out of favor. But applying surgical principles to the liver anatomy, the liver is a parallel organ radiobiologically as well, with functional subunits which are arranged parallelly and not serially. And so ablation of a certain volume of the liver using radiation should be possible as long as you don't damage the rest of the normal liver tissue. So in the 2000s, as I mentioned, then came the technology which made this possible. And this included conformal irradiation, which used multi-leaf collimators to shape the beam to the tumor. Computerized treatment planning systems were suddenly available, which allowed the generation of dose volume histograms, which basically showed how much of the liver got how much dose. The concepts of tumor control probability and normal tissue complication probability came up, and stereotaxy, which is the how to accurately reach the target with respect to an external coordinate system, was borrowed from the radiosurgical concepts in the brain treatment of brain tumors. So we slowly moved from partial liver irradiation to the whole, from whole liver irradiation to partial liver irradiation, and we quickly found that there is a strong volume threshold in the liver, and it is possible to irradiate very small volumes of the liver to very high doses, which would be tumoricidal. And around 2002, from the seminal paper by Dr. Dawson et al., from the investigation of the normal tissue complication probability, it was realized that no cases of radiation-induced liver disease were seen if the mean liver dose were able to be kept less than 28 gray for cirrhotic livers and slightly higher for non-cirrhotic livers, such as patients having liver metastasis. So the next technological advancement which helped us to do stereotactic body radiation in livers was the ability to visualize the tumor motion and reduce the tumor motion with various techniques such as compression belts, active breathing coordinators, and voluntary breath hold machines, or to reduce the impact of motion on target volumes by using techniques such as tumor gating and tumor tracking. Finally came image guidance, which used imaging systems on the treatment machine, such as X-rays, cone beam CTs, or megavoltage CTs, in order to enable proper visualization of the tumor at the time of treatment delivery. Usage of fiducials is also quite common nowadays, and rigid immobilization is a must for frameless stereotaxy. So basically, we could say that image guidance slowly took over the role of the stereotactic body frame, which was initially how stereotactic body radiotherapy started off. All these technological advancements made possible hypofractionation. Hypofractionation is the philosophy of delivering a very high dose per fraction of treatment. This is usually more than around 3 to 4 gray per fraction. And shorter, this enabled the delivery of shorter schedules of radiation rather than the 4 or 5 or 6 week treatments that we were all used to before this. And individualized dose prescription came to be adopted. This is something again that is unique in that it enabled the delivery of tumoricidal doses based on the liver function and the volume of liver that can be spared below a certain dose. So essentially, it kept the rates of radiation-induced liver disease below a certain threshold, and the prescription doses would be delivered based on this rate of radiation-induced liver disease. And current rates of classic RILD in contemporary series are well below 5%, whereas non-classic RILD is something which is more and more being recognized, and that is anywhere in the range of 10 to 30%. So the philosophy of Sbrt uses any machine, planning system, or planning technique, but it has to combine conformal radiation, image guidance, respiratory motion management, and the use of hypofractionation in order to achieve tumoricidal doses, which increases the tumor control probability, which is the TCP, and reduces the normal tissue complication probability. So just going through the evidence available currently, I'm sorry, I'll go through quickly for the early stage HCCs. These are the common situations which radiation oncologists have patients referred to them. So in early stage HCC, patients were not for transplant. Those who are ineligible for other ablative liver-directed therapies due to technical reasons, either due to tumor location or other medical comorbidities, as well as patients who have recurrence or residual disease after these local liver-directed therapies. So several prospective studies have reported very high local control rates in these patients in the range of 85 to 90%, depending on the tumor size and the percentage of patients with Child-Pugh B. And very high local controls. And this is just taking you through the the previously largest retrospective series from Korea, which again showed very high local controls with 2 separate dose schedules, upwards of the range of 90% at 3 years. But you can see that there is a proportion of patients with intrahepatic recurrence, which is the most common pattern of recurrence in patients with pre-existing cirrhosis. Again, emphasizing the high local controls of these patients. So basically, Sbrt is very effective as a local ablative therapy in these patients. And these are patients who are most of the time not eligible for the other therapies. So it can sort of take over that role in these patients. So as Dr. Kaisar mentioned, this is the article which I was lucky to be a first author on. Again, showing long-term outcomes of almost 300 patients who had no macrovascular invasion. So they were intermediate to early stage, but without a macrovascular invasion. These were patients, majority of whom were ineligible for other therapies. Majority of them were heavily pre-treated. Like I mentioned, a lot of them had recurrence or residuals post previous therapy. And in spite of all this, the overall survival at 1 year was around 77%, and 3 years was around 39%. And as you can see, the influence of the baseline Child-Pugh status is quite significant, as was the ECOG status of the patient, and the fact that if such patients went on to have liver transplant, they had significantly better survivals. So the median OS for, say, patients with Child-Pugh A status in this series was around 31.7 months, and local recurrence rates were in the order of 13.3% at 3 years. So just one key point, that there are several reported series reporting that the status of Child-Pugh B and C patients. So this was a prospective study again from the Toronto group, which showed that Child-Pugh B and C patients who were treated with Sbrt had a median OS in this series of around 7.9 months only. And among them, the Child-Pugh B7 had a significantly better OS than Child-Pugh B8 or higher. And these patients had a significant risk of decline in their liver function post SBRT, which is documented by the decline in Child-Pugh score at 3 months, more than 2 points. And almost 63% of these patients who were evaluable had a decline in the Child-Pugh score. So you have to be very careful with patients who are Child-Pugh B8 and above if you are offering them stereotactic radiation. So toxicity in the current series, in the most recent series, classic RILD is very rarely seen. What we more often see is non-classic RILD, which is basically elevation of transaminases, which is usually transient, as well as a transient decline in CP score. This can peak around the 1 to 3 months after radiation, but even this in the recent series is around only in the order of 12% or less. Grade 3 GI luminal toxicity can be dose limiting, and we have to be again careful because it depends on the proximity of the tumor to luminal GI structures. And so for all patients, in all patients with such tumors, dose and the image guidance needs to be tailored individually. So talking about patients who are on the transplant list, and specifically with respect to downstaging and bridging. So bridging refers to the treatment of accepted transplant patients who, while on the list, to avoid dropping off, and is more relevant to the cadaveric liver transplant, whereas downstaging refers to those patients whose tumor burden is outside the accepted criteria. The important thing is that response of the tumor to downstaging therapies seems to be a predictor of the tumor biology and predicts for no recurrence in the transplanted liver. So this is to bring to your notice a series which was a retrospective series, again from the Toronto group, which looked at propensity matched comparison between 3 groups of patients who were all on the transplant list. And so most of them underwent TACE, another group underwent RFA. And usually patients who are not eligible for both these interventions were those who underwent SBRT as bridging. In spite of having such bad baseline prognostic factors, the dropout rates from the transplant list were similar, and the overall survival was similar in all these 3 groups. So SBRT is an effective modality for bridging towards liver transplant. And looking at downstaging, for downstaging, there needs to be a delivery of ablative doses to the tumor without causing liver dysfunction. In bridging, sometimes what we do is we can reduce the doses, and we don't need to go to very high doses to all the tumors. However, in downstaging, it usually requires the use of very high doses to these tumors. So just a series of the reported series showing SBRT being used for downstaging or bridging. So transplanted, most patients go on to transplant, and they have the waiting times look around 7 months, and their survival seems comparable with the existing cohorts. These are some series which show the pathological complete responses in patients who had downstaging with SBRT, and they have a high rate of responses, around 24 to in some cases around 60% of patients having a pathological complete response. So SBRT as a technique to downstage and bring about complete responses in the pathological explant is an effective modality. And this is another study which is a randomized trial. Now in this, patients were randomized to surgery versus neoadjuvant RT, but this was 3D conformal radiation. And so it was a lower dose of radiation, and these patients all had portal vein thrombus involving either the main portal vein or the branch portal vein. In spite of that, almost 20, and so their responses were assessed at around 1 month post-RT, which I would say was a little bit too early for responses in the vascular thrombus. But the primary endpoint was achieved in that the overall survival was significantly better in patients who received neoadjuvant RT before going to surgery. So as a summary, almost all patients who receive radiation as bridging are reported to proceed to transplant. They have very low rates of toxicity, and they have very encouraging rates of pathological response. In intermediate and advanced stage HCC, this trial is the landmark trial by Dr. Dawson and the Toronto group. Basically, it was a phase 1, phase 2 trial with around 100 patients, and a significant proportion of whom had vascular thrombosis. So, unlike the previous trials, which I showed you with early stage HCC, these patients had really large tumors, and a significant proportion also had vascular thrombosis. And in spite of this, the median survival in the entire cohort was around 17 months, ranging from 10 to 21 months, and excellent local controls of around 87% at 1 year were reported. Now, only the presence of tumor thrombosis and being in the second trial was significant on the multivariable analysis. So the recanalization of the vascular HCC is potentially also can facilitate TACE, which is less effective in the presence of main branch portal vein thrombosis. And complete and partial responses are seen in about 37% and partial responses in around 75%. But these rates are highly variable, and the time to the maximal response, which is what Dr. Bedrell was also mentioning, can be typically more than 3 months. And so a partial response at 3 months may still have a possibility of improving if you repeat the scan at 6 months. This is a randomized trial which was recently reported from the Korean group. And this randomizes patients with portal vein thrombosis and Child-Pugh A status to sorafenib, which is the standard of care, and in the experimental arm, patients received TACE as well as Sbrt. The primary endpoint of this trial was the week 12 progression-free survival rate, which was significantly higher in the TACE-RT group than in the sorafenib group. But what was also encouraging and heartening was that the median survival was also significantly better in the TACE plus RT group at around 55 weeks compared to 43 weeks with sorafenib. So this is just to demonstrate a case which we had recently with a patient presenting with a diffuse infiltrative tumor HCC in the right lobe and with a tumor thrombus in the right posterior portal vein. Patient was planned for Sbrt followed by TACE, and received 40 gray in 5 fractions to the tumor and the thrombus. Tolerated it excellently, and this is the response at 3 months. His AFP came down dramatically, so a good biochemical response, and also there was a partial response in the parenchymal tumor with more than 60% reduction in the size of the tumor itself, and partial recanalization of this right posterior portal vein branch, and no change in the Child-Pugh score. So this is a typical, so this is at 3 months, and this was without TACE because incidentally, because of the lockdown, they were having logistic difficulties in getting TACE done. So actually this patient had an excellent response to the Sbrt alone. So this brings us to the current guidelines, where unfortunately Sbrt, at least according to the European Association, does not figure very significantly in the current scheme of things. As you can see, advanced stage tumors, the recommendation is for first-line systemic therapy, and even in intermediate stage tumors, it's chemoembolization. So there's no mention of radiation really here. And this is attributed to the low level of evidence that is currently available, and hopefully we can address it with the randomized trials which are ongoing currently. The Korean guidelines and the Eastern guidelines are a little bit more generous. They do advocate for external beam radiation in the situations that I mentioned previously. Those patients who are ineligible for surgical resection, unresectable, or are ineligible for other lever-directed therapies, as well as those who have portal vein thrombosis. The NCCN guidelines also from around 2018 do recommend the use of loco-regional therapy for patients who are not a transplant candidate, and they specifically mention that among the loco-regional therapies there is no, they are not in order of preference. It is a cafeteria approach that they advocate for, that the patient should have all these options and then should be able to choose from among them. So that is for unresectable HCCs as well as those who are medically inoperable. So common indications for SBRT, just to sum up, are the medically inoperable early stage HCCs, patients who are planned for transplant as bridging or downstaging, those who are ineligible for TACE, RFA or TARE due to technical reasons, either due to their vascular anatomy, coagulopathies, or due to the tumor location, and those who have a recurrence or a residual post-TARE, RFA, TACE, microwave ablation, or ethanol injection. Patients who have HCC with PVGT, of course, would not be initially eligible for TACE. So they can be offered SBRT either alone or in combination with TARE and TACE. And also for oligometastatic disease, either synchronous or metachronous, SBRT is very technically feasible and clinically useful. The selection criteria which one must be aware of when we are sending patients for SBRT, or as radiation oncologists when we select patients for SBRT, definitely prefer patients who have Child-Pugh A or B7, although we don't get a lot of them. Also, technically speaking, they should have 700 cc of the normal liver, which should receive less than a threshold of 15 gray. Up to 5 lesions is preferable, and no extrahepatic disease is preferable. The future, however, looks much more conformal than what I've been showing you so far. So protons have practically minimal beam exit dose, and so they can spare more of the liver than photon-based SBRT. So this can stretch the indications for external beam radiation, and HCC is one of the group 1 ASTRO approved indications for proton therapy. Several different fractionation and dose schedules are followed all throughout the world, especially in Japan, where they've been doing it since the 1980s almost. And they do show several series with high local control rates with very low toxicities. So this is probably the only randomized clinical trial comparing an external beam radiation modality directly head-on-head with TACE. Unfortunately, the results of so only an interim analysis is available still now. But even in that, patients who have received proton have marginally better, tending towards significance, better local control, as well as progression-free survival. As expected, they also have less complications, which was the primary endpoint of this trial post procedure. And again, encouragingly, the pathological complete response in those patients who underwent liver transplants from these is significantly better with proton compared to the TACE arm. This is just to share with you a recent patient which we treated with protons, and this is the sort of responses that we're seeing, which is extremely gratifying, especially as these patients don't have a lot of other options remaining. So this is 3 months post-proton, and we went to around 57 gray in around 20 fractions for this patient. So as a conclusion, I would say that SBRT is a non-invasive ablative modality in HCC, which has a role to play in all stages. It is associated with typically very high local control rates. However, patient selection is key in order to optimize their overall survival outcomes. There is definitely a need for improved evidence, and we hope these randomized trials, of which the RTOG 1112 is the one which is being championed by Dr. Dawson. This compares sorafenib versus sorafenib plus SBRT. So SBRT added to the standard of care in patients with macrovascular invasion. Also, there's a randomized trial which compares proton beam therapy versus photon SBRT in unresectable HCC. So this is a NRG trial which is happening in the United States. And interesting thoughts which are coming forward are also the combination of immunotherapy with SBRT, because SBRT is typically believed to be more immunogenic than the conventional fractionation because of the high doses that are delivered in a single fraction. And it is to be seen whether this will have an added impact when delivered along with immunotherapy. So thank you so much for your patient listening. I'm sorry.